Okay, today you're going to be talking about the kidneys. We're going to go over a lot of stuff with the kidneys in terms of filtration, secretion, reabsorption, and we'll talk a lot about how, urination will actually occur after we've gone through the whole process of, that reabsorption cycling through the kidneys. So reabsorption, filtration, and secretion, and kind of how the body reabsorbs things and nutrients that it needs. So I got this diagram here. I want to start off by labeling a couple parts, and then we'll start off by talking about the glomerulus and the Bowman's capsule, renal capsule, and then we'll kind of work our way through the system here, okay? So this right here is going to be the afferent arteriole. That would be this here. This right here would be the glomerulus capillary. I'd actually call it glomerulus capillary bed. And that would be this section here, okay? Glomerulus capillary bed. This right here, this is called the, glomerulus, right? And then this is called the Bowman's capsule. Okay, so this is the Bowman's capsule. If that's Bowman's capsule, then this is the efferent arteriole. Okay, so afferent glomerulus capillary bed. That's where filtration is going to occur. Efferent arteriole right there. Okay. Let's make sure I didn't miss anything. Okay, this section right here, that's Bowman's capsule. This section here, this is going to be the proximal convoluted tubule. Okay, proximal convoluted tubule. And that'd be this section here. Okay, then this would be the descending tubule. We call it the descending limb. And this part here, this is the ascending limb. This part here, but that consists of the descending limb and the ascending limb. This is called the loop of Henle. Loop of Henle, okay? This is the distal, right Actually, I don't want to write it right there. I'm going to be needing that space. So this right here, this would be the distal convoluted tubule. Okay? And then, so that would be that section there, and then this would be the collecting duct. I don't know if we can see that. Try to bring it in a little bit. Okay, that's the collecting duct. So, I believe I got everything on here. Part of this is in the cortex, part of it's in the medulla. So it's going to dip down. It's kind of like right here, cortex, medulla. So we have the afferent arteriole that feeds into the glomerulus capillary bed. Filtration occurs here. Then we have the efferent arteriole descending here. We now have the glomerulus, and then we have Bowman's capsule. Then we have the proximal convoluted tubule, and the descending limb, and the loop of Henle, and then the ascending limb, which the descending and ascending make up the loop of Henle. And then we have the distal convoluted tubule, which leads into the collecting duct, okay? So that's just a little bit of kind of a roadmap of where we kind of want to go, and we're going to kind of start up here at the top, and then we're going to kind of work our way down, talk about everything that's occurring throughout this that we need to know for this kidney section, okay? So I call this renal glomerular filtration. Up here at the top. So this would be number 1. Okay, renal glomerular filtration. And something that's going on with this is we have a couple things going on here. I like to think that this is kind of the main part where we get filtration. Okay, there's 2 parts to filtration that we want to know. The first part is the endothelial lining. Of this filtration. And that has to do with fenestrated capillaries. Okay, fenestrated capillaries. Then the second thing is the glomerular basement membrane. Okay, so if we have the endothelial lining, that is going to be occurring up here, and then we have this glomerular basement membrane, which is in blue right there. This is our glomerular basement membrane right here. Okay, so what we know that occurs here is first we want to talk about fenestrated capillaries within the glomerulus. Okay, so right here is going to be number 1, okay, which connects us up to here, which is fenestrated capillaries. So imagine we have all these capillary cells right here, okay? Well, they allow for filtration to pass through these sections here, okay? And we allow for this passing of these substances that can occur through here. So when we think about this process, we have these things right here called fenestrative pores. They kind of occur right through here. Okay, these are called fenestrative pores. And what these do is they allow nutrients and things to come in. So if we had a fenestrative pore, they would allow for nutrients. They would allow for amino acids, right? And electrolytes. And we call them small proteins, right? Small proteins. And water to come in. But it doesn't allow formed elements to come in, like red blood cells, white blood cells, platelets. Those things can't penetrate in. So it starts this filtration process, because in our blood we have all these nutrients, we have amino acids, we have everything that we need for the sustaining of life within our blood system. And then we have these pores that will filter out some of the things that we need to have filtered within the kidneys. So that leads us over here. So we kind of understand that there's these fenestrative pores, right? The other thing we need to understand is there's something here called the basement membrane, glomerulus basement membrane, right? Well, the glomerulus basement membrane basically has these charges within it, negative charges, right? And it has this layer within it called the lamina densa, okay? Lamina densa. And these are important because these will attract these positively charged ions. Sodium, potassium, magnesium, calcium. So we allow for them to pass through, but negatively charged ions like albumin or IgG or fibrinogen, they can't pass through as easily. And so that kind of inhibits some of these things that we don't want to pass through from coming through. So we have these things called plasma proteins. And that'd be like albumin. IgG. And fibrinogen. Okay, so we have these things, and these guys are all negatively charged ions. And so these proteins, right, immunoglobulins as well, and so they don't get through. But then we have something over here as well called electrolytes. Right here, these guys are called electrolytes over here. Lights within our blood, and we have sodium and potassium, right? We have bicarbonate, HCO3. We have chloride ions and magnesium and calcium, right? And then we have some other nutrients as well that we try to filter through. We call these substances, we call these nutrients. Okay? And these would consist of glucose, amino acids, carbs, lipids, fats, right? Urea, creatinine, vitamins, but most importantly, water, H2O, right? So all these things have a way, because it's about size, it's about charge, right? That allow these things to pass through. How big is it? And then its filterability. How positive, how negative is it, right? And that determines if they're going to be able to pass through and actually be filtered through this filtration process. So we have filtration occurring, we got water, we got all this. We know that when these guys come down, they immediately get pushed back up. Why? Because they're negatively charged. When these guys come down, these guys actually get pulled in because they're positively charged and they want to come in. And as I explained with the glomerular basement membrane, right? Glomerular basement membrane, that also aids in this filtration process. Now there's a couple of things here that are going to block this as well and aid in this filtration process. Yeah, right here we have something called a filtration slit, which is also going to try to, and it's about 25 to 35 nanometers in diameter, but it's going to try to block some things from getting in as well. And then we have a nephrin protein as well, nephrin protein, and those are going to try to block some of those things from getting in through filtration. So we're going to bring in all this stuff into the cell, okay? And like I was saying before, most of this stuff is like glucose and amino acids and carbs and lipids and creatinine, urea and creatinine. Right? And then we're also going to bring in HCO3 minus and Cl minus and K plus and Na plus and calcium and magnesium. Right? We're going to bring all these things into our hopefully we can see that still. Is that good? Okay. We're going to bring all these things into the cell and into the nephron here for filtration. Okay, so now I kind of want to talk about some pressures. Okay. So we kind of want to talk a little bit about clearance over here. A little bit about what that is. So the formula, or clearance, is the volume of plasma being cleared of a substance X per minute. Something we use is creatinine. So something we're trying to calculate is GFR, right? And that's glomerular filtration rate. Net filtration rate times KF equals our GFR, okay? KF is just a filtration coefficient, and so if we have NFR over here, net filtration rate, and our filtration coefficient on this side over here, then what we end up having is we have this thing called GHP over here, glomerular hydrostatic pressure, and we subtract that from VCOP plus CHP. And we find that NFR or NFP equals GFR. Right? And when we do the math, this is a 10 millimeters of mercury net pressure out. Okay, then we have a, on this side, we would have surface area, number one, and then number two, we would have permeability of glomerulus. Permeability of the glomerulus. Okay, so hopefully that makes sense in terms of how we calculate some of these things. So one thing I want to note is that how this works is you have your afferent arterial right here, right? We've already kind of discussed this a little bit. Afferent arterial right there. And over here we have our efferent arterial here, okay? When we pump in our blood through here, you know, we have 1,200 milliliters of blood, okay? 1,200 milliliters of plasma flow into the glomerulus. Now, depending on the blood pressure, on average, we have about 625 milliliters that comes in, okay? And then coming out this way, we have about 500, and I believe it's 75 milliliters. So we have 625 milliliters coming in being filtered. So not everything gets filtered, but we do have a large amount that does get filtered within the kidney here. Now you have something pulling it through the membrane or pushing these substances through this plasma liquid, and that thing is called glomerular hydrostatic pressure. Okay, and it's pulling the fluid out at 55 millimeters of mercury. Okay. On the flip side, we have CHP, which is about here, because when it funnels in, it backs up on itself sometimes and pushes pressure up. And so CHP would stand for capsular hydrostatic pressure. This is about 10 millimeters of mercury, okay? And that's going to be pushing up, back in to the glomerulus, to the glomerulus. Then we have our B cup, and that's because of a protein up here called albumin. Attracts the fluid to come in at a rate of 30 millimeters of mercury. Okay? And that's how our pressures are working. And so if we net this, we actually get a net, let me see. I believe this one's 15. So we get this net pressure inward or outward of 10. Okay, net 10 millimeters of mercury out. And therefore we pull fluid out. So this is filtration. This is going to be occurring at the glomerulus, the capillary bed, where it's involved with the glomerular basement membrane, where it's involved with these endothelial lining fenestrative capillaries, which allow for this filtration process to occur. So in talking about clearance, clearance is gonna have this formula that we want to know. And this is clearance, and especially if we use something called creatinine. Because we know on our charts creatinine has 100% reabsorption, or 100% secreted. And so we know that, like, if we had 157 milliliters per minute and normal's 125, normal's 127, and we had 127 milliliters, then this would equal GFR. And that would be our creatinine, as I labeled up here. And then clearance is going to be, clearance equals U of X times the rate over P of X. Milliliters per minute. So if clearance increases, then our urine increases. If clearance decreases, then our urine decreases, but absorption, reabsorption is going to increase. Okay? Now I want to talk about one last thing. It's called tubular fluid plasma. It's called the TFP ratio. And basically, if we had a graph like this, if we had 1 across and this equaled 1, then our TFP ratio would be 1 for sodium. Sodium is 1 for 1 H2O. So it's unchanged. And then if we were up a little bit like this, this would be glucose. No, this would be more like Cl minus and creatinine. And then if we went down really low like this, then this would be our glucose. So that means this would have lower tubular fluid. Okay? So that's just a couple things we want to know about that. Okay, let's talk a little bit about reabsorption. So with reabsorption, that's going to be occurring here in this thing called the proximal convoluted tubule. Okay? So we have our proximal convoluted tubule. In this thing called the proximal convoluted tubule, we know that coming into the cell, we're sitting at about 300 milliosmolars, okay, per liter. So, coming into the cell, we have a lot of things. We have water, we have electrolytes, we have nutrients such as glucose, we have lipids, fats, vitamins, and then we have these things called small proteins. Okay? So we know that 100% of glucose and amino acids and lactate, right? 100% of these things are reabsorbed. of those reabsorbed. Okay? So with this, we have a couple things that we need to note. That is, lactate and glucose, they're going to enter in through a transporter here on the membrane. And we have a lot of these things right here called sodium potassium pumps. Those 3 sodium out and 2 potassium in. And they kind of drive these transporters because potassium wants to come in, sodium does, and then we have glucose come in and we have lactate come in. Using that, then through this we can allow a transporter to occur for glucose and lactate, and then they can travel into the blood. Okay, through the transporter. Normally that'd be a little bit closer. So glucose, lactate, 100% reabsorbed, and they're doing that through a sodium facilitated channel. Now glucose can do the same thing with sodium, so sodium comes in and our glucose comes in as well. But then we also have this channel where we reabsorb 65% of sodium right here. And water's going to follow the salts. So we have these things called porins. And then the water will flow through and we reabsorb just as much water, 65% of water gets reabsorbed in this reabsorption process. We also get sodium chloride to be reabsorbed through a channel here. So we would have our sodium and we'd have our chloride, and they get reabsorbed and they come through here, right? And then they're able to come into the blood. Okay, so we can get those puppies into the blood. We had something going on with carbonic acid as well. that we're also bringing into the blood, but the main ones are just getting those glucose and things into the blood. And amino acids 100% are reabsorbed as well, but if we had this, we would have a sodium pump here with this amino acid. Okay, and then both of these can then make it through this transporter, and we also have a sodium potassium ATPase pump there, and then these guys can make it into the blood. We can get sodium in the blood and we can get amino acids reabsorbed. So it's all these are using sodium to Na+ to get back into the cell. And then through a bicarbonate process we can get CO2 out of the blood, and then we can create, you know, hydrogen and water and carbonic acid, then carbonate protons, and then the protons will filter through with the sodium. So right here we can have these protons come out, right? We'd have these protons come out, and then we'd have these sodium ions coming in. Okay. So that's about all we need to know for proximal convoluted tubule. As we now go into the loop of Henle and into the descending ascending tubules, there's a couple things that we want to know. First off, we have the loop of Henle here, right? If we have this thing called the loop of Henle, then we have our descending limb and we have our ascending limb here. Okay, this is H2O, permeable, solute, impermeable, aquaporins, yes, and H2O wants to go to medullary interstitium. We call this the countercurrent multiplier. Then our ascending limb, we would have our sodium, potassium, 2Cl pump. Call this a co-transporter. Okay, co-transporter. We have one sodium out, one potassium out, 2 chloride ions out, and 1 potassium in, I believe. Or maybe they're all out. Yeah, they may all be out. So we have this thing that occurs where, you know, our osmolarity is going to stay about 300 because everything that left is going to be about the same. 300 milliosmolars, right? And then we have all of these water channels here. Water's going to be leaving all the way throughout this process. And we notice that within this fluid, we start, 300, then we get to, 500, then we get down to 700, then we get down to 900, then we get down to about 1200, right? And same thing in the blood, this ends up becoming 500 and 700, and then we have 900, and we have 1200. So what ends up happening is we have all this secretion that occurs up here. We have a really important channel here, ion carrier here. This is called the Na plus K plus Cl2 minus 2Cl minus. Okay, and all these things are gonna now come in here. And because they're in this space right here, they attract the water. So the water is wanting to come over, okay? And when the water comes over, then we have this state where water has traveled and is being reabsorbed. We're reabsorbing the water, which is a really good thing. So as we descend, we're increasing salt, and then as we descend, we're increasing osmolarity. And intermedullary interstitial spaces getting more salty and pulling that water over, okay? And this process is what's known as the countercurrent multiplier. Okay, countercurrent multiplier. Now, you now have this thing called the ascending tubule, and that's what the ascending tubule is contributing. This is what's going to be called our vasa recta, and we're going to get to that here in a little bit. Okay? But for now, this is kind of what's going on, and it's what's most important. So we've talked about tubular secretion, where it's coming out, and tubular reabsorption, where it's coming in. Tubular secretion is going to require ATP. We've talked about the percentages of what we keep and where we're at. This is where things get pretty important. At this point in the process of the kidney, we're at 20% sodium left, 20% water, and we're at 10% sodium, and we're at 100 to 200 milliosmolars. Right? So something that we have on the membrane here, if this is going to be a cell, part of the cell, we have this thing called the chloride sodium channel. And these guys are pumping through sodium and chloride ions. And the chloride ions can come through a channel here, and then if we had the blood continuing up here, they would just come right into the blood stream there. Okay. We also have a sodium potassium pump here. And so as we have 2 sodiums out, 3 sodiums out, we would have 1, 2 potassiums in, right? Now this requires ATP, as we know, primary active transport. So in the distal tubular duct, something that can be happening as well is this high reabsorption of salt, which is sodium. These are called principal cells. Okay? These are called principal cells. Okay, glomerular cells, or principal cells is what we call them, okay? So if we have principal cells, we have the same sodium potassium pump that's occurring over here. I'm kind of going to draw it out just a little bit. But right here we have the same sodium potassium pump where we have 2 potassium coming in and 3 sodium going out. And this helps with this thing called aldosterone, is what kind of kicks up this sodium reabsorption. We have something over here that we call the adrenal medulla. Actually, we just call it the adrenal gland. And this adrenal gland is stimulated by angiotensin II and also stimulated by decreased sodium levels and increased potassium levels, concentrations, right? So this thing, the adrenal gland, we have these globular cells that then activate aldosterone hormone. And aldosterone is going to come over and it's going to activate this pump here on the membrane called this sodium pump, reabsorbing sodium. And then we have this potassium pump, releasing potassium. And then we have these things called aquaporins that can get activated and allow water to come through. So this is one of our final steps of reabsorption that can occur. Okay, so we have reabsorption occurring of water. And we know that ADHD can stimulate that. ADH can stimulate these antidiuretic hormones, can stimulate these aquaporins. So what they do is they open aquaporins, allow water to flow in, and then the water follows the sodium ions in the blood, so we increase the blood volume, which increases blood pressure. So the last thing we have is this thing called the collecting duct, which is this whole section here. We have these A cells and B cells. These are for acid, these are for base. Okay, and so we have something on here. we have this structure right here. We would call this, you know, we could call this structure the hypothalamus. And what this does is, using angiotensin 2, it's going to take ADH and these neurons actually release ADH, and then ADH will go and do its thing. But if we have high acidity in the blood, so it's acidosis, and we want to get rid of hydrogen, we can bring CO2 into the blood, and we can combine it with water, and then we allow these two molecules to mix, and we make carbonic acid, H2CO3, and then that can split into HCO3 minus carbonate, bicarbonate, and hydrogens. And then the hydrogens will use a transporter, allow potassium to come in and these hydrogens to come out. So this way we can secrete these hydrogen molecules, and then hydrogen can now combine with ammonia, and then they can make ammonium. And then when they make ammonium, then we can secrete that in the urine. And then would have Cl coming through the transporter there. And one other thing that we want to happen sometimes is bicarbonate to come back over here. If this was blood, then we want that bicarbonate HCO3 to come back in to balance out the acidity. It's the same thing, but vice versa here, okay? And then we have urea and all those things. So this one would be for alkalosis. Okay, so I believe we covered everything. We got everything done. We start up here in the glomerulus capillary bed, then we feed into the Bowman's capsule. From the Bowman's capsule, this is filtration. We then go into this reabsorption and secretion process through the proximal convoluted tubule. Then we hit the loop of Henle, which would be our descending and ascending limbs. This is where water reabsorption occurs because of the ascending tubule that has, the ascending limb that has the sodium potassium chloride channel pump that allows the attraction of water. Then we ascend up. We're low in the solutes, but that's a good thing because we're trying to reabsorb everything. We now come to this potassium chloride channel where we're trying to reabsorb this potassium. Okay, and then we come to these principal cells where, you know, we're now acting on aldosterone hormone with angiotensin, and we have this we call it the RAAS system that occurs where we have this sodium potassium pump channel up here at the top that's occurring, and then we have this aldosterone hormone that's going to activate these sodium channels and these potassium channels and allow for the secretion of potassium, but this reabsorption of sodium, which then activates also these aquaporins. ADH will also activate those aquaporins, pull in the water, and then in the collecting tubule we have some other things going on as we try to balance our acidity and alkalosis and acidosis within the blood, getting rid of or putting bicarbonate in the blood or these hydrogen ions. and the hypothalamus modulates this with ADH. And so we have this process of filtration, reabsorption, secretion, and excretion is the final thing as we urine. And that would be the final piece to the puzzle. Okay, well, this is the kidney, and thanks for watching.